Welcome back, everybody. As you can see, we are moving from the Pacific coast towards the Atlantic coast. And so I would love now to invite to the podium, or to the table and then the podium, our presenters from the Atlantic region. For New Brunswick, we have Kristen Barnes, the Director of Operations at the Canadian Mental Health Association of New Brunswick. From PEI, I believe we're bringing in by video Sharon McNeil, who is with PEI Metastatic Breast Cancer Survivors. For Nova Scotia, we have Louise Gillis with us, who is the National President of the Canadian Council of the Blind. And for Newfoundland, because our working group representative, Andrew Goss, the founder and past president of the Canadian Psoriasis Network, wasn't able to join us in person, I believe Antonella Scali will be presenting, thank you, will be presenting on his behalf, and Antonella, as you know, is the executive director at the Canadian Psoriasis Network. Thank you so much, everybody. Just get yourselves ready, and maybe we'll start with Kristen. Great.
All right, so on behalf of New Brunswick, I will say that our working group is kind of representative of myself, who works in mental health, and I also self-identify as someone living with a chronic condition, as I was born legally blind. And the other member, Linda, who is representative of the Arthritis Society. So in terms of our scope and our feedback, that's kind of what we were working with. So prior to putting together some of our slides, we did actually, or I took some time to kind of consult with a few different societies related to medicine and health in New Brunswick, and also some of our consumer networks, patients and caregivers. So the information that we've put together is our perspective. You might see a little bit more on the leniency in terms of mental health from my side, as well as some feedback related to, say, chronic pain or arthritis from Linda's, but we tried to capture as much as possible with some additional data as well. I will apologize. I'm not texting, just because I'm legally blind, I can't actually see what I'm presenting. But to your benefit, I also can't see you texting. So in terms of the top three, our slides are kind of broad, and I will provide more context to them. So in terms of the issues that we identified, some of the feedback and what we would say, number one would be access. So access in terms of wait times for services related to surgery, related to mental health care. There's regions in New Brunswick, specific to mental health, for example, where in order to receive free one-on-one services, you're relying on the government system, which can take actually up to 18 months to receive a counselor, or 2 years to receive a psychiatrist in some regions. So for individuals presenting with mental health concerns, that's a long time to say, just hold off and we'll get you connected to somebody, and, here's some support groups or other things in the meantime. So wait lists for surgery, chronic pain specialists, other types of specialists as well. We also see, just even in terms of referrals, so referrals for, say, a potential cancer diagnosis, other potential diagnosis of chronic conditions, those are also of concerns for us as well. In terms of lack of affordable health care, because there is such a shortage in terms of the public health care, a lot of individuals are reliant, unfortunately, on the private sector. We also have now seen certain professionals, say like a psychiatrist, who's actually opened private practices outside of the public health system, but of course at a cost, and those costs have become, unfortunately, quite high. Many benefit plans are also costly, and even for Linda, who on our working group pointed out, even in terms of the copay or what some of the benefits would actually provide, it actually becomes quite unaffordable or difficult to balance as well. Not all healthcare benefits are actually covering all the medication needed, and so in terms of that affordability, sometimes they'll cover the basics, but not maybe the more specialized medicine that's needed for individuals. We also see private being quite expensive. So for those who can't access certain tools or certain accessibility features or other things through public funded services, you're outsourcing tools or treatments or other things on a more privatized way, which is also more expensive. And I use the example, being legally blind, I was very fortunate to receive a technology that actually allows me to see at 20/20 vision. They're called eSight glasses, for those of you who have never heard of them. But retail, they're $12,500. So it comes at quite a cost, unfortunately, and that's not something that's covered under healthcare. So I use that as an example, or for individuals who are accessing, say, a psychologist or other practitioners outside of the formal system, they are not always covered under certain things. So we also have 2 separate health authorities in New Brunswick. So when you look at us, we're a very rural region with 3 main cities. Of course, a very small province, but the way we're divided up, we have a French regional health authority and an English regional health authority, both that span the entire province. We are dependent on ERs and emergency services, unfortunately, for a lot of our services. So because we don't have the public regular services, a lot of our ERs are actually seeing the low to moderate mental health requests, among other low to moderate chronic pain requests, in addition to all the emergency and acute care. And just to build in terms of resources, when we talk about affordability, for those of us who can't work, I know John mentioned a great statistic around those who aren't working sometimes because of mental health concerns. On a Canadian scope, 500,000 Canadians miss work every week because of a mental health concern. So if you talk about affordability and those who are unable to work, even due to other concerns, that statistic is pretty large. And in terms of lack of focus on prevention, we have a huge focus, unfortunately, in New Brunswick, where we are really reliant on intervention as opposed to prevention. There are different prevention measures, but certainly a huge focus of our funds are very much directed to the intervention-based work. So we see that as an issue. 61% of New Brunswickers live with at least one chronic health condition. 70% of New Brunswickers are either overweight or obese. And in terms of the intervention versus prevention, recent statistics over the last few years have actually shown that 70% of those who've died by suicide in New Brunswick didn't access any formal mental health or addiction services. And over 70% of those who died actually consulted their family physician on an average of 3.3 times within 6 months of dying. And so when we look at those statistics and what we have available for, whether it be evaluation, treatment, screening, or prevention, those are, of course, concerns for us. In terms of the barriers, lack of resources, a recent poll from the New Brunswick Medical Society showed that on average, and those who are responded to the poll, 44,000 Canadians don't have a family physician. New Brunswickers, 44,000 New Brunswickers. And being a small province, for some provinces that might not seem like a large number, but for us it's quite significant. And in terms of the availability of medical clinics or other things around the province, those very much vary depending on the region that you live in, especially if you're rural versus urban. We also have 20.8% of our population right now are seniors, which is actually the highest proportion in Canada. In terms of siloed service delivery, we do struggle with information sharing amongst the sectors, amongst mental health and physical health, as well as just generally in terms of serving clients, and as well as lack of meaningful public and client engagement. We would say that's one of the larger barriers that we have when we're not seeing as many clients consulted, or even yesterday I heard someone refer to consulted in a meaningful way or meaningfully involved and not only listened to but also heard. Some possible solutions that we had talked about is the implementation of an effective medical model. So we talked about value-based healthcare. We've talked about stepped up and stepped down care models, both in physical health and mental health. There's a lot of community-based services in New Brunswick, as there are across many provinces, and unfortunately, those aren't always implicated in the service delivery. So because we are working in silos, we'd like to see those broken down and really integrated into the medical model. We'd also like to see the province taking on goals similar to the federal government, so we can align what we're doing. Within this medical model, we see more prevention and health promotion as well as intervention, and appropriate utilization of services, so not driving people at low to moderate into the ER where there are significant wait times to be seen. For increased funds, we want to see those implemented strategically. We don't have enough family physicians to serve many needs. There's a lot of individuals waiting for referrals. We also see lack of services related to not only the physical health but the mental health side of things. So looking at how it's being implemented and involving more effective ways of serving the outcomes that the clients and the patients are looking for. We also talked about parity between mental health and physical health. 70 to 80% of medical visits are stress related, yet we're still separating mental health and physical health. And I know that's a theme that I've heard talked about already from the East Coast or West Coast to the East Coast. So when we look at those statistics, we see more than ever the need to really have that parity amongst mental health and physical health. In New Brunswick, only 7% of healthcare funding are actually allocated to mental health. But we see the parity. So we see the parity really not being seen. And then finally, in terms of collaboration among sectors, I did kind of already delve into that a little bit, but we see the importance of that collaboration piece. We also see the importance of recognizing certain practitioners that aren't necessarily always recognized. So right now, one of our strengths is we are, as a province, looking at recognizing Canadian certified counselors as practitioners that can work in the formal system, whereas to date they haven't been. So that's limited us in terms of the scope of what we're able to offer. So that is something that New Brunswick is actually moving towards, but there's a lot of other practitioners that could be recognized to help serve those who are in need. And I know I've probably gone over my time, so I apologize.
So I am the national president for the Canadian Council of the Blind, which is an organization of blind people working with and for blind persons across Canada. And I travel throughout the national scope of Canada, from Newfoundland through to the West Coast. So at one time I did live in Western Canada, and somebody asked me, well, where are you from? And you're from the East Coast, aren't you? And I said, yes. Well, where in Ontario do you live? So I had to straighten out their geography a little bit on that. So I am going to be representing Nova Scotia in this aspect as best I can, because apparently I'm the only committee. I'm the committee. So our top three issues that I find are clinical shortage, long wait times for treatments, overcrowding, and ER backups. So on here I have a few slides, but I'll have more information as I go through the topics. And some of it is more of a national scope as well as provincial. Nearly 5 million Canadians do not have regular physicians, according to Statistics Canada. And there is definitely a health crisis. Some of the news headlines prior to the federal election: healthcare crisis in Nova Scotia hits the federal campaign. Though healthcare is delivered by the province and territories, Canada's federal government has a crucial role in terms of funding levels, setting healthcare priorities, and making sure that access and availability is equal across the country. that is questionable. Many still struggle with issues around inaccessibility and unaffordability when it comes to health care, particularly the cost of prescription drugs, medications, and that aren't covered through public plans or employers. On the issue of long-term care for aging Canadians, there are consistent standards across Canada, such as understaffing at residential homes. The Conference Board of Canada found that the demand for long-term care beds was 263,000 people in 2016 waiting for beds. In Ontario alone, the wait list is 32,000 people in 2017. And in Nova Scotia, I don't even have the numbers because many of the people waiting for beds are occupying active care beds in many of the general hospitals across. Now that the Liberal Party has been re-elected, we need to see that they will move forward with more accessible care, shorter wait times, and better health outcomes. Well, Liberals, here we are, and let's see what happens with the money. A spokesperson for the Nova Scotia Health Authority suggests emergency departments have become de facto primary care centres for people who have no family doctors. We too have orphan clinics as well as Quebec. And orphan clinics look after all the people who don't have doctors, and when a new physician comes into the province, then those orphans are doled out to that physician. Everything that doesn't get cared for elsewhere ends up in the emergency department. And this is a quote from Dr. Milburn, who is the coordinator of emergency coverage in Antigonish and Cape Breton. A major hurdle in access to primary care is that the vast majority of family doctors and health professionals are located in urban centres. Gaps in emergency services undermine the principle of universal access. Frequent closures of emergency departments in small hospitals resulting in overcrowded in regional hospitals. And I'll have more information on this as I go through it. Nova Scotia doctors are paid less than in other provinces and are taxed at a higher rate. Nova Scotia's doctors' shortage means too many people are flooding emergency rooms to seek care. And there is a retirement boom in the physician status. But recruiting efforts still face obstacles from within the physician's ranks. One particular doctor in Amherst is retiring just now due to health issues, and he spoke to some new recruits that Nova Scotia is not the place to come to. Go to Alberta or Ontario. So that is great encouragement for us. Because I'm involved in eye health mostly, I've put a comparison here between Ontario versus Nova Scotia in wait times for something as simple as cataract surgery. And the numbers are here for your reading pleasure, but in a short view of it, the average wait time in Ontario is 87 days, while in Nova Scotia it ranges from 262 to 332 days. To get in for even consultations before you get your surgery. That also involves other eye conditions as well. Many other diseases are very similar. The wait time for mental health, for instance, most particular in the teenage sector, since we've had a lot of suicide rates recently, is 2 years at the very least to get in. So if I have a problem now, it may take me several months to actually admit that I do have a problem before I even go to a family doctor to get a referral to mental health, and then have to wait at least 2 years to get in to access the care. Solutions. Well, solutions didn't come in the right place there. There it is. This is a great thought to have a solution, but how do we get the solutions? Yeah, and I was just asked to give 3, but there's more. One is funnel more money into the healthcare system, and doing that, you're recruiting more, trying to get more money in to recruit more people. Special measures need to be pursued to address access in rural areas. Government would provide an additional, this is what was promised prior to election, $6 billion in funding over the next 4 years, tied to negotiations with provinces and territories. How much will the rural areas get of that money? Recruit more, excuse me, my tongue is not working with my mouth. Recruit more clinicians by providing a more equitable pay system. So what's happening in Nova Scotia in particular, the main center is Halifax. They're the highest paid of all doctors, family practitioners, as well as specialists and whatnot. Then next comes the Cape Breton Regional Hospital area, which is where I live near. They get the kind of the second pay. But after that come the rural areas, who get very little pay in comparison to any of the rest. But also they have very little people to help them with it. When a car accident happens on one of the mountains on Cabot Trail, they go to the smallest hospital, or the closest hospital, which is Neils Harbor. 9 times out of 10, the hospital emergency is closed because there's no funding for it. What do the ambulance drivers do with this? They have to try to hopefully get into the Cape Breton Regional Hospital, which is close to a 2-hour drive away. In that drive, when they get there, because all the other local emergency hospitals have been closed because it's a weekend and the emergency doesn't work in Glace Bay or North Sydney or any of the other smaller outlying areas. And this happens as well in the rest of Nova Scotia too. So that patient ends up maybe coming and waiting in an ambulance outside because all the beds in emergency are occupied and no room to get in. Eventually they will move inside the building at least, but the ambulance cannot leave because they have to attend to that person because there's no other staff to look after them. So recruiting more clinicians can be helpful, but we need more money and more funding for that. Train more clinicians, and that includes not only doctors, including in this nurses, nurse practitioners, and technologists. Doctors Nova Scotia hopes an upcoming round of contract negotiations with the Nova Scotia Health Authority will produce improved conditions for attracting and retaining doctors within the province. There are currently 72 openings for full-time family doctors across the province. The Health Authority says that that includes current and other vacancies in the future from the retirement age. So their plans are to recruit 51 doctors per year. So that doesn't even cover the openings that are currently there. Just a few days ago, the Nova Scotia government and Doctors Nova Scotia have reached a settlement on a new wage contract of 17% increase over 3 to 5 years. But I'm not fully aware of how that is going to be doled out. Is the majority going across the board to all the doctors, that's 17%, or is it going to the ones who are getting paid less now? Are they going to get the more money to bring them up to par with the ones who have a better pay? We don't know. Daily announcements of emergency department closures have become a routine on local radio stations in Nova Scotia. Every part of the province is feeling the effect as outlined in a chart from the Nova Scotia Health Authority, and this is a chart that was way too small for me to even put up on the board, but it's something like this, if you can see it, because I can't even see it in my hand. But in June, there were 4,600 and some ER closures. and in August it improved a bit. There were 3,473 closures. So that just goes to show the lack there. Some other parts that are also affected are the drug programs for eye care in particular, and relating to the what can happen across the country. The RAPID program in Alberta, for instance, if that were to come, then eye care would be drastically hindered in that, because what they're proposing in that is the first line of treatment for age-related macular degeneration is to use an off-label drug which is far cheaper than the ones that are currently approved by Health Canada. If that happens, eye care can go down the tubes quite quickly because we have an aging population and a lot of not only macular degeneration, but also we have a high incidence of diabetes in our communities. And these drugs are used for that same eye disease as well. I feel privileged to have had eye disease in the fact that I've had to leave my employment because who wants a blind nurse walking around looking after them? But I've come out on the positive end of that by being able to meet so many wonderful people across this country, but also internationally through the US and through many of the other global countries such as China, Malaysia, Thailand, and many more European countries and whatever that are working to try and improve the quality of lives. And we can only take some hints from some of those places and bring them into our countries to hopefully improve that quality of care. One other, if I have another moment. In Yarmouth right now, if somebody is pregnant there, they may not be able to have their baby in their community hospital. If all of a sudden they go into labor and have to go to a hospital, to their local hospital, they may not have an anesthetist. So therefore they have to drive 2 hours to get to the closest local hospital ready to deliver their baby. So most of those things are things that we've been encountering. There's many more, and wish I had more time to tell you about them, but it's been an honor to be here. And having lived with a physical disability since the age of 2, I know what it's like, and that's a disease that will come back, and it does haunt me to this day, and is taking its toll. But thank you for being here. And a lack of sight is not a lack of vision. Thank you.
Thank you so much, Louise and Kristen. I think you both did a great job of capturing some of the common issues that we see across Canada, but across the Atlantic provinces in particular. And I invite Louise to add anything to what I'm about to share, as well as anyone else who may have experience in the Newfoundland health system. Just again, to place myself, I'm from Ontario, and I'm referring to some very high-level perspectives from Newfoundland, from Andrew. Again, this is representing not all the experiences there and all the health conditions, so I'll be giving you a high-level idea from specifically a psoriasis lens. But just to add to the concern about access to treatments, one of the major things that I think we see across Canada, but was highlighted for Newfoundland, is even when a medication treatment, a drug is available through the public drug plans, doesn't always mean people get access to them. And that doesn't happen very efficiently for people as well. So again, speaking specifically from psoriasis, in Newfoundland and I'm sure across Canada, there is the problem of having to kind of go through a rigmarole of trying a first level treatment before getting approved for potentially a newer line treatment that could be more effective for somebody, especially if they have more severe symptoms. So the challenge with access goes beyond just if it's available and down to the actual nitty-gritty of what getting the treatment means, and I'm sure that's the same for a lot of chronic conditions. to highlight what Louise said, again, another major issue is, I'll start with primary care. It's a big challenge, and Newfoundland is not a small province, so being able to get the support that you need in your community becomes extra difficult. And in a case like psoriasis, where your best bet is getting a dermatologist to an early diagnosis and consultation becomes even more difficult, because your entry into that is through a referral with your primary care physician. So that continues to be a challenge. And then availability of specialists, that I believe you mentioned as well, in rural locations especially, is particularly challenging. And when we talk about chronic conditions, I'll use psoriasis again, we know that there's multiple associated conditions, so things like cardiovascular disease, metabolic syndrome, mental health issues. And I like the example of the whole body piece, like your liver, your kidney, your skin isn't in St. John's, it's wherever you're living, right? So I think that's a big problem for a lot of people, and I know from the mental health space as well, that's a big challenge in Newfoundland. And I think those were the main challenges. I think one of the solutions that have been talked about already is, expanding the options of nurse practitioners, the option of teledermatology, and what can we do to make it easier for people to access those types of resources, whether it's in their province directly or from resources that exist across Canada, because there are some really good opportunities there. And I think another big solution that Andrew talked about was, it is that culture shift that Eva mentioned, and value-based healthcare is a model that we can look at for, how do we change it so that we're looking at treating the whole person, and having the system kind of follow that person, rather than having the patient follow the budgets, or following those silos, or falling into those silos. So that's the high-level challenges that I think really reflect kind of what we've been hearing across Canada, but show specifically that in community or in provinces where it's a large province with a few city centers, those problems become a bit more profound. So thank you. And again, if there's anyone here who has experience in the system and wishes to add to it, we're always welcome to have you do that as well.
And last but certainly not least, we will be bringing Sharon McNeil in from PEI via video conference. Hopefully. But I got a big nod from our AV guys.
Good. Okay. Hi. So my working group is just me. Who else said that today? But I did try to go out and interview people in the healthcare field, and just sort of surreptitiously kind of have little chats with them, and because people didn't want to be giving their opinion on things, like it was very difficult. For me, the main issue in healthcare is drugs. And that's all I would have presented had I have not spoken to other people. So we have long wait times for innovative drugs to be added to our formularies, both oncology and non-oncology drugs. And also, a lot of people seem to think that if it's a drug administered in the hospital, it's covered. You don't have to worry. But in many provinces, you do have to worry, because if that drug is not on that provincial formulary and it's given to you in the hospital, you're paying for it. Well, you just won't get it. We also went through a period of time, and I think this is improving, but where we had very high copays for drugs that were oral or subcutaneous. So they might be on our formulary, but a lot of our formulary drugs were income tested. And because we have, I guess, perhaps a lower average income, perhaps than many provinces, those thresholds are very low, and they increase quite a lot as your income goes up. I'm still saying, like somebody might have an income of $80,000 in our province, and they might have had a copay at one time of $5,000 a month, $60,000. Well, that's not affordable, even if you're a high income earner in PEI. So We also, a lot of people suggested to me that we have very, very long wait times for mental health services for adults. I don't know about children, but I assume it's just as bad, sadly. I'm sorry, I can't address that. And we also do have a shortage of doctors, both GPs and specialists. So those were our three main healthcare issues in PEI. Barriers, well, no money, no money, no money. I say that and I laugh because many of you will know that over the last 4 years, PEI's economy was one of the fastest growing in Canada. Although that said, I don't think we're really a wealthy province, but if you're starting at the bottom and you're growing fast, you could still be at the bottom. But we did have we still do have a very well-performing economy right now. We hope that lasts. But we got into a period actually from May of 2015 until I'm going to say August of 2019, where we had no new innovative drugs added to any of our formularies, nothing. And I recall a previous health minister announcing that there would be no more funding for drugs for quite some time, since any additional funds that arrived from Ottawa via the Health Accord were to be allocated to mental health issues and home care issues, which I'm sure they were needed. But that really resonates with me, because I know it wasn't until we had a new health minister and one very brave woman in our province spoke out about her issues accessing a drug, and she used a social media campaign, and it really caught on. That we had a breakthrough, and our previous government did all of a sudden announce that 28 drugs would be added to our formulary. Some were cancer, half cancer, half non-cancer drugs. I had a chance to speak to that health minister and thank him for, thank you for those drugs. We're still behind. And he said, I never ever want to have to go through again being affronted on social media with people's health concerns. Why wouldn't people come to me directly? Well, I'm not going to answer. I didn't answer him. But I think a part of our barrier to drug access is also what we refer to as our list approach to drug approval. So I don't really want to spend a lot of time on that, but there is a process that we have to go through to identify what drugs will be considered for review. So when the minister announced that he has money for drug funding, and it's at his discretion, it's not mandated in the budget, it's at his discretion, then we go through this approach to review our current list. Do we want to change anything on it? Should we add or not? And this list includes oncology and non-oncology drugs. And the members of the committee, some of our doctors will bring forward new drugs that aren't on there. So this is a problem. We only have one, for a long time, we only had one medical oncologist. It's not a lot of opinion. It's just one opinion going in, funneling into what's a drug that we need to have. We now have two medical oncologists and a hematologist. So I think that will be helpful. But once our list approach, everything is ranked. It's quite a process to rank it. And nobody knows how much money there is. Then the minister says, here's the money you have, now go down your list. If you want to, say, approve funding for drug number 28 on that list, you have to have enough money for all those drugs that are above number 28. We never deviate from going top down on that list, because we don't want to give the perception that people can come to the minister and ask for their drug to be approved and they will get it. So that comes with a lot of problems. So barriers to mental health, moving on. Nobody had an opinion. So I said, well, I guess we just don't have enough money. I'm not sure why that isn't more of a priority. And as for doctors, I know that PEI our physicians are not the least paid in Canada. I know they're not. Thank you, Louise, from Nova Scotia for commenting on that. But I think that we're just not a very attractive province to new physicians to come here. Like, if you come here, chances are you're going to be set up in a rural area. There's more need in rural areas than in our two small cities. And also chances are that you're going to have a large client base of aging patients. And that comes with a lot of challenges. And as for specialists, like I just, if you graduate from medical school and you put that time in to become a specialist, like you really want to go somewhere and build your career and get involved in cutting edge medicine or, whatever, you're not going to get that here. So I think we're just not attractive to new physicians. That's what I think. So solutions. At one time I thought, oh, great, equalization, increasing equalization payments, but we're hearing a lot of backlash in that area right now. So I don't know what will come of that, but a firm commitment from the federal government to help with PEI's many health concerns. But I think this is my personal opinion. I think it's good when the federal government says you can have this money, but this will be allocated to mental health, or this will be allocated to pharmacare. I prefer that. Now, I know my province didn't, but I think that's an important area of any equalization payment, that, because if we leave it up to our health ministers, we can go through another period where our health ministers will say, I'm sorry, but I haven't got money for drugs. Even if money is allocated for pharmacare and it's not specifically tied to pharmacare, there's no accountability on the part of our health minister to put that money to pharmacare. It's his choice. As for the shortage of doctors, because I am not sure that we'll ever be an attractive province. We don't have Montreal or Vancouver or Sunnybrook, we just don't have those facilities. So I think, I personally, I would rather see a nurse practitioner for minor concerns than wait 3 months for my GP to fit me in. I haven't had to do that, but I know some people do. I would rather Skype with a doctor on the internet and hope that they were a good doctor. And we do that in some areas in our province. We offer a video conferencing with doctors where we have a shortage of rural doctors here, and I think it's been working out quite well. As for specialists, I think I would like to see. Everybody says, no, you can't do that. But everybody says, well, if we could do that, that would be a good thing. I don't understand why in the Atlantic provinces we can't have more and more sharing of resources amongst ourselves. We do share a lot of project money is shared and split between the Atlantic provinces. You know what? Here's an example. I have to see a neurologist, and I can't understand why I have to see a locum from Halifax, because we have 2 neurologists in this province now. Well, for referrals, one neurologist has a 3-year waiting period, the other has an 18-month waiting period. So I phoned up the clinic in Halifax where this locum is coming from and said, I'll drive over to Halifax if I can see this doctor faster than waiting for him to come to PEI. And I was told I would have a year's waiting list, but if I just sat tight in PEI and waited for him to come over here and provide services here, 3 months, 3-month waiting period. I cannot understand that, but I think somehow in the sharing of services between the provinces, we can do a better job than just trying to locate a specialist in one province. So that's an option. And the other thing I was thinking about when I just heard Louise talking was, I don't know why it is that we pay doctors more money when they are located in a city, an urban area, maybe we should look at incentives, more money for rural areas, more money for doctors, at least in Atlantic Canada, who are prepared to take on a greater percentage of the aging population and patients who of senior ages. Like, hey, pay you more. Well, it's an option. So that's it. That's all I've got. Thanks.
Thank you so much to all of you. Questions or comments?
Thank you. I have a question maybe to Louise or to anybody who cares to respond. I think that many of the solutions are very concrete and very pragmatic, but I think that they don't necessarily reflect the fact that behind each of these solutions, there are priorities. And I think that there is no question that I think that this summit is really talking about changing priorities. But I still feel like, in some small provinces, maybe a shortage of doctors or difficulty in access is circumstantial. But in a province like Quebec, for example, the shortage of doctors or difficulty to access mental health services is inadvertently intentional. I mean, when there is a decision about how many doctors should be per capita, and it ends up of having 40 or 45% of people without GPs, it's something that has been designed for a long period of time. So my question again is, how do we shift the conversation? Because it's really interesting. I think that we are talking about changing priorities here, yet all the solutions, or most of the solutions that are being offered, don't really talk about how we change the conversation. So I just wonder, and again, I don't know that it's possible to do that nationally. It may be a conversation that has to be taken, be held in each province, but I think that there is really something that is missing here, just really shifting the conversation.
There's kind of two things that we tried to do this year. Every year we do these summits a little differently. So this year, the first day was just obviously to get us all in the morning on the same page, that we're talking, we all know what social determinants are, we all know what value-based healthcare is, we all know the state of affairs with all our national processes in health, national and provincial processes in health. And then we talked about value-based healthcare, which is really the future. In my view, that's a vision for the future. And I hope that you were encouraged by the end of the day by hearing about the work that Jennifer is doing and the work that the conference board is doing with Eva to, do some proof of concept that this is something that we should be rolling out. And today, because there have been so many changes in governments over the last few years provincially, and changes in, therefore, really in the political parties that are in power, and therefore the sort of political landscape, I thought it was time for us to catch up with the provinces and find out, since these people have been around for a little while, these new politicians been around for a little while, has it really changed things in the provinces, and does it mean we should be doing some things in the meantime? So I'm kind of a long-term, short-term kind of person. I always want to have a vision of, where I want to get to. And I want to work on that vision, and I think we are. And also, though, we got to keep, as I think it was Eva said earlier, like, people can't be dying because our existing processes are like inefficient and have gaps. So I want to keep the people alive today to the extent that we can, so that when we do get our vision of the revolution, that they'll be around to enjoy it. So it's kind of that mix that we were going for this year. Some years we've been quite granular, and some years we've been very visionary, and this year we kind of did a bit of both. So your point is exactly right. We do want to change the conversation about what is health, what is value-based health, and we want to start talking about a simple definition: patient outcomes over cost. It's not rocket science, and then get the services going there. In the meantime, it's obvious that there are problems with the existing system that some of the best practices we heard yesterday might help to solve. So I guess I think we should work on both, but that depends on what others want to do. I'm happy to work on both, and I think there are some other people who are as well. But you're right, there will be some of these things that I actually have heard pretty much the same thing all morning in different ways, and some a bit more shocking than others. And as you say, some of them you kind of can understand maybe, but some of them are just ridiculous, given the resources that should be available. So I think that the solutions may not be so different, but we will then have to go province by province to get them implemented. That's kind of the way I was seeing that. But value-based healthcare, I think that's a change for our whole country.
And after lunch, those of you who are staying, patient, caregivers, et cetera, okay, I've got 2 people on the list, and then I'm sure people are starving. Just to prime your thinking, those of you who are remaining for the afternoon, that's exactly what we're going to start to do, is group by region and start thinking through what are the opportunities to work together on any of these issues.
I was just doing some Google searching here, and one thing I found is when it comes to specialists and lack of specialists in rural areas, there was a talk at O'Brien Institute, which I was in Calgary, and a gentleman said that 70% of the time, specialists don't need to see the patient, they need to see the data, and then they could consult remotely.
Yeah.
Now that's very difficult if all the data is in one province, let's say in the East Coast, and you have specialists in Toronto. So just food for fact. The other one is, according to CTV News, 1 in 5 specialists are unemployed. So we don't have...
Oh my God.
It was actually published today. 1 in 5 newly certified medical specialists are unemployed in 2017. Right? Now, if unemployment rate of 20% existed in the oil industry or auto workers or even aviation workers, politicians would be on the soapbox protesting. But these are white-collar workers, right? And so that's just food for thought. That's my opinion. That's not the article's opinion of why they don't get the attention. And the third is when it comes to recruiting specialists to rural areas, I think times have changed, and we have to factor in the fact that the old school is that most physicians, let's say a long time ago, were male, and then they had their spouses who followed them because they didn't have a career. Today, it's flipped. Most of them are women. Most of them are both professionals. They're married. My late wife was an optometrist, and I would resist her from moving to a rural area because it impacted my career. So it's not so easy as saying we need to recruit people in certain areas of the country because you have to factor in family dynamics. And I think a lot of the solutions could come by coming back to releasing that data, and rather than making provincially centric, why can't we have people to access specialists across the country? Right? Why do we need to move the doctors to these areas? And I say that with respect with the people in the East Coast, but there's rural areas across the country. And leverage technology in order to provide services and equally.
Last but not least.
This is actually very good that I'm last because it's not so much to what you're talking about. The comment is very inspiring to be in a room full of people that want to speak up and want to be part of the solution and want to collaborate with each other. But it's even more inspiring when a lot of those people, like a huge percentage of those people, are already struggling with chronic diseases, with physical or mental disabilities. It's even more shocking because we have a lot of things to deal with personally, and we're still making the time and making our voice be heard and trying to speak for us and for all of those around us. And I feel it's our responsibility, but I also feel it's our responsibility to tell the people that are coming behind us, if you come out of the other side victorious, you have a responsibility to share your story. You have a responsibility to speak up, because you know what? It's not just your story, it's the story of a lot of people, and a lot of people that were not as lucky and could not tell it. For a case like Cheryl or Louise or you guys, how many cases are of people that didn't make it? In my case, how many people like me committed suicide because they couldn't enter the system? So a lot of you came to me and said, thank you for sharing your story. For me, it is my duty and it is an honor. And I feel that I have to do it because you know what? I made it. I'm alive, but a lot of people didn't. And I have a 15-year-old daughter, and I see so many issues in that generation coming through with the technology nowadays, so many mental illnesses that are developing and things that we are not ready to cope with because we didn't grow up with the same things that they are growing up right now. So I have to speak up. I have to be that voice because I don't want my daughter to go through the same things. I want to pave the way for her. And her generation is going to deal with way more issues than us. So I feel that we have to do it. There's no option to sit down, and one beef that I have with the recovery-oriented model is that it's very subtle and, oh, well, no, that's okay. You don't have to share if you don't want. You know what? You have to share. You have to speak up. You have to say, I have a voice. We have a voice. You have to make sure that people know about you. You have to create community, and you have to speak up, because if not, things are not going to get any better. If I give you guys my card, if you look at the back, I love Dr. Seuss. And in my cards, I have a quote from the Lorax. Unless someone like you cares a whole awful lot, nothing is going to get better. It's not.